Good morning, good afternoon, and good evening to all of you. My name is Cyril Engman, and I am the Senior Director at PATH and practicing pediatrician and professor of pediatrics and public health at the University of Washington. I will be moderating the session. On behalf of the entire team, I'd like to welcome you to the session, which will outline the journeys that countries have taken to scale up care of the small and sick newborn. It's about a decade ago that we started discussions which eventually culminated in the Every Newborn Action Plan. In fact, I see many faces from 2013 and 2014 when we launched this wonderful Every Newborn Action Plan effort. But before, during, and even after ENAP, many countries were and continue to work on scaling up care for the small and sick newborn. So in this session, we're going to focus exquisitely on the country perspective. You will hear initially from Dr. David Gutara, who's an assistant professor at the London School of Tropical Medicine and Hygiene and part of the NEST 360 program. He's going to talk about the state of the evidence. Then Dr. Kirsten Israel-Ballard, who's the acting team lead for the Maternal Newborn Child Health and Nutrition program at PATH, we'll talk about the Neolins Project itself. Then you're going to hear from our country champions from Malawi, from India, from Rwanda, and from Ethiopia, who will be interviewed by Dr. Trish Coffey, who's a senior advisor at PATH. Kimberly Emunson will take you on a virtual tour of a NICU, and then there'll be a question and answer session, which I will moderate. So please put your questions in the chat box. Thank you, and over to you, Dr. David Gutara.
Thank you, Cyril, for that introduction. I'll walk you through the state of the evidence and highlight some of the implementation gaps for the small and sick newborns. The WHO has, through the recently launched standards for newborn and for small and sick newborns, have outlined the WHO levels for newborn care with the interventions, and you can see right there on the screen, and what's highlighted are the level 2 special newborn care interventions that need to be set out to help us achieve some of the 2025 newborn coverage targets. Next, please. And some of these targets require that 80% of the districts have at least level 2 inpatient neonatal units with respiratory support, including CPAP. Next, please. And as part of the WHO standards for care for small and sick newborns, we have this framework that outlines the different domains that we need to invest in to have quality care, and this span from provision of care to experience of care to health system resources. And within each of these, we have standards that we should implement. And an example is provision of care, where we have evidence-based practice for routine care management, having actionable health information systems, functioning referral systems, ensuring that we have effective communication, respect and protection, and dignity in the care that we provide, and more importantly, emotional and psychological support for children and mothers within these units, and ensuring that we have systems that have the right spaces with the adequate resources, but importantly also adequately competent and well-motivated human resources. Next, please. But despite these standards and policies, there is a gap in the how-to evidence to implement some of these standards and guidance and recommendations. And UNICEF, alongside other partners with NEST 360, are in the process of creating an open access, practical resources and active learning platform that allows to bring together all the resources and practical learning that we need to implement newborn care interventions. And this is organized within the 7 health system building blocks with the addition of infection prevention. And this is bringing learning from across countries and from from multiple channels and across different partners. Next, please. So And here is an example of the main partners that we're working with, and more are coming to join in. Next, please. So the platform is organized by the health system building blocks, with the family at the center, as outlined in the WHO standards. And next, and the way this is organized is that we have, for each of the different health system building blocks, then we have themes within each of these, and within each theme, then we describe what is expected. For instance, for workforce education, then we provide the tools required for workforce education, which means examples of curriculums that integrate learning, clinical protocols, and devices, background reading, as well as in-practice examples, which include case studies and other in-country experiences that we are learning from, and we'll see some of those in the upcoming presentation. Next, please. And here is a huge welcome to this platform. It's still under development. We are encouraging people to join us, send us an email to any of those 2 email addresses to join this broad membership and contribute to the development of this great platform, which brings together this, the resources that support implementation. And follow these Twitter handles for more updates on this implementation toolkit.
Thank you for that introduction. We will now move into talking about the Neolins Project itself, which is really a roadmap. We are going to walk through the journeys that 4 countries have taken to scaling up care for their small and sick newborns. We'll be talking with national stakeholders and hearing their stories. Next. Many of you will recognize the graphics and the images here. We certainly globally and in country have made significant achievements in prioritizing, addressing, and scaling up and improving the quality of care for the small and sick newborn. And yet formally documenting this process has been lacking. We know that we need to continue providing special and intensive care to this very vulnerable population in order to achieve SDG 3.2, so that we reduce neonatal mortality. But in order to do so, we have to have sources, documentation to understand what has been the scale-up experience, what has been the historical perspective of establishing inpatient care. Identifying this level of detail has been challenging in the published literature. In order to really inform expansion and true scale up of the system, we need to understand the country level pathways. How have those who have achieved this experienced the establishing of these models of care? This is vital to continued learning and also to drive forward priorities and investments. Next slide. So our Neolins project, the lessons learned in establishing inpatient newborn care. The aim of this project is to describe this roadmap. What has been the roadmap of these 4 countries to reduce neonatal mortality in their countries over time? You'll see here they're highlighted from 1990 to 2019, massive gains in reduction of neonatal mortality rates. Next slide. The Neolins Project, a Bill and Melinda Gates Foundation initiative, is helping us to document these journeys. What have been the various approaches taken? What barriers and enablers have these countries encountered? What have been their lessons learned? We're doing this through in-depth case studies. Again, the 4 countries, Ethiopia, India, Malawi, and Rwanda. Initially, we began with a desk review looking at focused policies and strategies in peer-reviewed and gray literature, conducting a comparative review, identifying where the small and sick newborn appears in these policies and guidance. How does it map to WHO standards with our new standards that we have? Moving forward into identifying what are the actual experiences and perceptions in country. This is through key informant interviews with in-country champions and stakeholders to try to really document what has happened in country over time. We'll culminate this work with the development of a virtual experience. We invite you to walk with us, to be immersed into a NICU setting, into the care systems for these infants, so that we can actually see these best practices in real time. And we'll be moving on to that shortly. But the overall aim of this project is to document and compare all of this so that it is a learning as we move towards scale, and we can improve access to the care for the small and sick newborn globally. Next slide. We'll be summarizing our findings from this work based on the WHO Health System building blocks, just as was mentioned with the NEST 360 project. As we look across these countries, what has been their journey across service delivery, health workforce, information, essential medicines, financing, leadership, government, infection control. We'll be looking at multi-country comparisons to see where has the small and sick newborn focus appeared. What is the country level governance, their innovation strategies unique to each country, partnership, funding, and looking at cross-country event timelines to really get a sense visually of the diversity and the roadmaps to how they've established these models over time. Next slide. Our initial findings have suggested that although we see content in policy and strategy documents related to the small and sick newborn, oftentimes it's limited, although it may not always depict what's actually being implemented in country. From a global perspective, there has not been a uniform funding approach. There must be more effective coordination at the country level to ensure alignment and a sharing of systems. Country level innovation strategies for implementation and infrastructure have been significant, and yet they require greater documentation and recognition if these are to be learned from, adapted, scaled. And we depict here two of these innovations, one from Malawi in terms of their equipment, and another layout of a new mother and newborn unit in India. And with that, I'd like to turn this discussion over to Dr. Patricia Coffey, who will lead our conversation with our panelists from our countries. Thank you.
Thank you so much, Kirsten. I'm very pleased to moderate this panel of subject matter experts from 4 countries, all of whom have been intimately involved in the journey towards establishing inpatient care for small and sick newborns in their respective countries. I have the pleasure of welcoming these 4 extraordinary individuals. First, Dr. Bogale Worku is a pediatrician and full professor at Addis Ababa University in Ethiopia, where he was the chair for the Department of Pediatrics and Child Health in the Faculty of Medicine for more than 5 years. He is also currently serving as the president of the Ethiopian Pediatric Society. Next, we have Dr. Kayinamura Mwali Assumpta, who is a public health pediatrician with 10 years of experience in implementing neonatal health programs in Rwanda. She holds a master's degree in pediatrics as well as a master's in public health. She is currently serving as a senior RMNCH specialist for the IntraHealth USAID Ingobi Activity Consortium. And next we have Dr. Sushma Nangia, who is the director, professor, and head of the Department of Neonatology at Lady Hardinge Medical College and Kalawati Saran Children's Hospital in Delhi, India. Her main interests are epidemiology, neonatal resuscitation, neonatal sepsis, respiratory care, and nutrition. Dr. Queen Dubé is a consultant pediatrician and clinical epidemiologist. She was recently appointed as the Chief of Health Services for the Malawi Ministry of Health. Prior to her new MOH post, Dr. Dubé was the head of the Department of Pediatrics and Child Health at Queen Elizabeth Central Hospital, the largest tertiary hospital in Malawi. Welcome, Dr. Dubé. So now I'd like to ask each panelist to address a set of questions. And the first set of questions is, to describe briefly what has been achieved in your country in terms of establishing systems specifically for inpatient care of the small and sick newborn, and then describe one or two challenges that your country has faced in establishing these care systems and how these challenges were overcome. Dr. Dubé.
Thank you, Patricia. It's an amazing question. And it's a story that I would love to share, perhaps for the whole day, but I'll try and summarize in 2 minutes. So what Malawi has done over the past 2-3 decades is to establish what we now call functional newborn care units. In simple terms, it's what WHO, the newly launched newborn standards, call specialized newborn care. So in all our district hospitals, the larger CHAM hospitals, and these are mission hospitals, we have established these functional newborn care units where we're even able to give CPAP to babies with breathing problems. It wasn't an easy job. It's taken years. We started the journey in 1999, just with Kangaroo mother care, and it's evolved with a lot of evidence and, getting the right policy framework, getting the right champions, getting the right paperwork in terms of protocol, strategies, working with district health management teams, professional associations, setting up robust data systems, and everybody else coming together as stakeholders under one umbrella that we call the National Newborn Steering Committee, with clear targets and deliverables. We are where we are today. So it's an exciting story. And looking at what it is that has been challenges, again, you can write a book, but you choose on the things that you want to focus on. So for me, the biggest challenge in the first place was the big question, how? How can we do it in sub-Saharan Africa? Looking at the resources, looking at human workforce, looking at financial resources. We realized that the policy framework was the easiest bit, but mobilizing resources and changing systems was the hard bit. But you know what? Start with one person, start with one facility. Learn, take that first step. Don't wait to get that $1 billion check. With the 1 cent that you have, you can actually make a difference. And rally around a strong team. With a strong team, you can overcome obstacles. So I personally don't like to dwell on challenges. I like to look at the opportunities that the challenges pose. Even in the US, you have 1 million challenges, but you've learned to look at things differently. And that's what Africa should learn. What is it that I can do in my context? So the challenge story for another day, but let's talk about opportunities that these challenges pose. Thank you, Patricia.
Dr. Sushma.
Hello, everyone. Thank you for this opportunity to be here amongst all of you and to talk about India and the way it has taken care of the small and sick newborns. So let me begin by getting the greetings from New Delhi, India. And India is a country with 136 crore population, with 28 districts and 8 union territories. So with that, the journey started when the National Health Mission was launched in 2005, which took care of the funding aspects of newborn care and the other maternal and newborn care. In fact, maternal, newborn, and child health. And after that, we had the Janani Suraksha Karikram, which is basically safe motherhood, wherein all the women who delivered at health facilities were given some incentive to come and deliver, which helped in increasing the number of deliveries which could be institutional deliveries. And then, of course, with the ENAP coming in, we had our own INAP, which was India Newborn Action Plan. And finally, we embarked on a journey for facility-based newborn care. Under the facility-based newborn care in 2011, the country envisaged to have 3 levels of care. The first was at every delivery point or every birthing area, wherein newborn resuscitation and essential newborn care was to be provided to all the babies being delivered there. And of course, to the mothers, the relevant care that was required. The next level of, and this was at the sub-center or the primary health center, which had a population of something like 3,000 to 5,000. The next level was the newborn stabilization unit, which was at the level of the community health center, also called, some of them also called as the first referral units in the public health system. And here we envisage to take care of not only the resuscitation and essential newborn care, but in addition to that, facility-based care, wherein small babies were admitted for taking care of these babies. If they were sick or if they had emergency signs, they had to be stabilized and referred to the next level. If they were not that sick, with mild respiratory distress, with just sepsis, which is uncomplicated sepsis and so on, they were taken care at the newborn stabilization unit, where we had one physician and 4 nurses, or in fact, we envisaged to have that kind of manpower. And the next level, which has really come up quite well in India, is the special care newborn unit. And about 800 odd SNCUs are already there in the country, which take care of small and sick newborn, almost everything being taken care except mechanical ventilation and any surgeries that are required. For that, these are sent to the next level, which are the medical college level. So how did we go about doing it? There were 4 pillars. The first was the infrastructure development. The second was getting the equipment. The third was employing the manpower or getting the human resource. And the last was capacity building for that. And we've been involved in all these. So I must just say that the first 2 weren't as difficult. The first, which is making the infrastructure with the funds that were available with the government, the infrastructures were created. So we had a 12-bedded special care newborn unit for every facility at the district level, which had deliveries of 3,000 per year. Similarly, if the deliveries went up by another 1,000, 4 more beds were added. So this was the level care system established at the district hospital. So getting the infrastructure and getting the equipment was not as difficult, although equipment was a little difficult because we had to have some specifications to be set as to what is the kind of equipment that's required. But the next 2 were very difficult in terms of getting the manpower employed and then training.
Okay, thank you very much, Dr. Sushma. So Dr. Mwali, would you also like to share a little bit about your systems of inpatient care for small and sick newborns in Rwanda, and also 1 or 2 challenges that your country has faced and how they've been overcome?
Thank you very much for the question. So Rwanda is the most densely populated country in Africa with slightly above 12 million. It's among the few countries that had achieved the MDG 4 and 5, but the recent DHS 2020 revealed a slight decrease of NMR from 20 to 19 per 1,000 live births. So Rwanda health system is organized in a pyramid structure from the highest, which is the Minister of Health, to the lowest, which is the community. At the Ministry of Health, there is a MNH officer who coordinates all newborn activity in collaboration with partners, including the Rwanda Pediatric Association. The coordination is done through the Neonatal Technique Working Group. And during that meeting, participants discuss on HMI's neonatal data and other new and ongoing intervention on small and sick newborn. In addition, advocacy is done for gaps observed during the implementation of activities. It's through that platform that the MOH organize also workshop to review all or to elaborate all documents related to neonatal care. For example, last year we adopted the WHO newborn quality of care standard. And this year we integrated those standards in the national accreditation document. We have also SBC messages for newborn to create demand for care. At tertiary level, we have only 4 hospitals comprised of 1 private and 3 public. Only 2 of them have a level 3 neonatal intensive care unit. Currently, the country has 3 neonatologists who are working in those tertiary hospitals. Pediatricians working in that level are also part of a national mentorship program that support the district hospital. We have also 30 districts with 46 hospitals, including 7 prevention referral hospitals and 39 district hospitals. These provide only level 2 NICU services, including Kangaroo Mother Care Service. Some of them at least have 1 pediatrician who provides small and sick newborn care. At health center level, all babies less than 2 kilos who are born there are referred to the district hospital. The sick neonates referred to the community are managed in the IMCI clinic, and those who identify with danger sign are provided with pre-referral treatment before being referred to the district hospital for further management. At community level, which is the lowest, we have community health workers who are in charge of maternal and newborn. They are called agents santé communautaire. They are responsible to provide postnatal care 2 and 3. In addition to that, they visit babies at 28 days for those who are low birth weight. And they refer all baby with danger sign and counsel mother on different topics, for example, danger sign and early seeking of care. The challenges we are facing mainly is the inadequate human resources for health. And this was addressed through the government partnership with American University, training medical doctors, and now we have a number of 100 pediatricians compared to 30 about 5 to 6 years ago. In addition, we do in-service training on essential newborn care and on neonatal protocol. And we do a continuous professional development through clinical mentorship and supportive supervision. The second problem is inadequate neonatal equipment and lack of maintenance of equipment. And this, the Ministry of Health have at least 1 technician, biomedical technician in each hospital, and partners are providing bioengineer to support maintenance where they have problem and also repair. The partners advocate also to prioritize procurement of spare parts in the budget plan of the district. That's I think the main problem. Over. Thank you.
Thank you very much, Dr. Assumpta, for that description of the care levels and the challenges. Dr. Bogale, would you like to also share from your experience in Ethiopia?
Thank you very much. It's really a great pleasure for me to be among this great team to share the experience of newborn health in my country, Ethiopia. The history of newborn health in Ethiopia is a very short period. It's around 1 decade. When I was in the university, I was teaching my students, and by and large, all colleagues from abroad used to tell us that newborn health is a sole luxury and very expensive, and you can't go beyond the major hospitals having newborn health. You cannot go to the small district hospitals with this type of services, and that was filled our brain. And so we kept quiet for so long. But later on, when we understand that newborn health is not so expensive as it was thought, and then we start, and myself also took the responsibility and decided to take sabbatical from the university and start to teach midwives and setting newborn corners with our partners helping the federal ministry. And the newborn corner where midwives are really taking care of sick babies and essential newborn care at the delivery room. And from this experience, we then said, why can't we have small NICUs in district hospitals and other hospitals? And then small by small, we started with 8 hospitals having NICUs. And now we have 230 and beyond 230 NICUs actually. So how we could reach all this level is through exactly shifting the tasks of pediatricians and medical doctors to the nurses, where the nurses are really trained, given an adequate skill, knowledge for only a couple of weeks. And they amazed us through their devotion and care for babies in their respective hospitals. And I tend to believe them because of the stories they tell us. One amazing story I just want to share with you is one of the district hospitals used to have a lot of babies dying in the hospital. And the hospital guards used to bury babies in the compound hospital and pay for each service they give when they bury babies. And when baby nurses are trained, go and went back to their respective hospitals. And after a couple of months, those guards came to the hospital management complaining, you must have outsourced the dead bodies to be buried because our resource has reduced. And then the hospital officers told them that, no, we didn't, but our nurses know what to do for babies and saves them, and a lot of babies being saved. And really this convinced me that the nurses are doing miracles. And in a country like Ethiopia, where you have more than 100 million people, having only few neonatologists, few pediatricians, then you can't do anything except using the low-level health workers or nurses and midwives who are really making miracles. So this really has a very great, commitment to me, that keeping on training them until we have pediatricians in the country. So this is a history really behind the newborn health in the country. So now the big challenge, of course, like any other low-income countries, the resource is a big challenge. Though the government is committed to purchase some basic equipments, and those equipments are not without problems. Once you invest on some equipment, you need to follow them up, and you have to have sustainably functioning equipment. So these are a major challenge that we are facing. And of course, the nurses, 4 weeks training, and then keeping them for years and years in one place with 4 weeks of training will lead to a burnout of nurses and looking for other alternatives, changing their positions. So the government now has come to understand that there is a need to have neonatal nurses. So we do have a generic training for neonatal nurses, and we do have also even these days masters in neonatology. So we have these categories of nurses really doing again miracle, and short of doctors and neonatologists. So this is a history, and within this very short period, I'm really happy that we could go all around the country and really set up a neonatal unit. Of course, the neonatal unit we have is not a level 3. And we are happy with the level 2 because by larger diseases that kill them are common conditions that are taken care by the nurses, like asphyxia, infection prevention, and kangaroo mother care, and feeding, breastfeeding are those major killers. So we are really happy with that, and of course, I'm looking forward to have the tertiary level cares also. Over to you.
Thank you very much, Dr. Bogale. So in the last few minutes of our panel discussion, I'd like to ask you each to reflect on your experience and then offer one piece of advice that you would like to share with other countries that are starting to implement the new standards of care for small and sick newborns. So let's start with Dr. Mwali from Rwanda.
Yeah, thank you. So for Rwanda, we have a strong leadership. This is a strong leadership of the country. This is the first thing. And also we need local leadership like champion at all level, from central to community level. And also have a collaborative partnership and an integrated context teller system approach to address the continuum of small and sick newborn care. Thank you. Over.
Thank you very much. Dr. Sushma, what would be your one piece of advice?
It's actually difficult to just talk about one piece of advice if people are embarking on the care for small and sick newborns. So with our experience, as I said earlier, the most difficult part is to get the human resources. And so here I would agree with my other co-panelists in saying that we need to do task shifting. We did not get pediatricians, we trained the medical officers, just the ones who are basic doctors. We didn't get doctors, we only trained the nurses. And I would say if we have to invest our energy in training the manpower, it should be our nurses. So train the nurses well, they will stay, they will be the ones who will take care of the babies. And second thing would be involve the family, give some of the tasks to the mother to look after the baby, she will be involved. This will help her produce more milk as well as she's there with the baby, so her anxiety is reduced. Involve the mother is the next one, and ensure that we have good clinical practices. Mother does kangaroo mother care, she expresses her milk, and that is fed to her baby. That's it. Thank you.
Wonderful, thank you. And Dr. Bogale.
Sorry, thank you very much again. The most important thing that I convinced myself is a need of champion, like my colleague from Rwanda said, and from India also. So you need to have somebody who is really concerned and believe that he has a mandate to change the history of the newborn health in his or her country. Then that person will really empower nurses. I really, again, will emphasize on empowering nurses, giving care for babies. And that will make a change. Unless, if you wait on for sophisticated equipment and highly educated personnel, then you change a little, only little. But when you really empower nurses, we have many nurses who are really there for us, then they can make a lot of changes. So that's what I really think pass as a message for my viewers. Thank you.
Dr. Dubé, you certainly have a wealth of information. And so based on your experience, we would love to hear just maybe one single piece of advice that you can share with other countries that are starting to implement the new standards of care for small and sick newborns. What might that be?
I think first things first. If you don't have the right policy framework, it's really difficult to get these things in a system. Otherwise, it ends up as a project in one little facility, and it doesn't have an impact across the whole country. So get the right policy framework. Get the right team, people that don't give up. Get people that have this faith that we can do it. And people that can take one step at a time. So right policy framework and leverage on partnerships. There's quite a lot that as countries we can achieve if you just get the right partnership. Stop working in silos. At the end of the day, the baby is not divided into 20 silos. It is one baby that we're fighting for. So leverage on the partnerships that you have in country, professional associations, donor organizations, professional bodies, actually the frontline soldier on the ground, that nurse, that clinical officer, that doctor, you need to figure out a system of getting them on board. So partnerships, right policy framework, but also people that can champion the cause. Get the right team. Thank you, Patricia.
Thank you very much. Thanks to all our participants for this very interesting conversation. And we will have an opportunity to have a live Q&A that will be moderated by Dr. Engman in just a few minutes, right after we hear a little bit about the virtual experience that we'll be also producing from Kimberly. Kimberly, over to you.
As part of the Neolins case studies, PATH is utilizing a novel approach to immerse the viewer into the journeys of establishing inpatient newborn care. We will create a virtual platform as an educational tool to allow the viewer the ability to virtually experience and tour an inpatient neonatal unit in one of our 4 project countries, while simultaneously highlighting the key features and unique examples from each of the 4 countries included in this project: Ethiopia, India, Malawi, and Rwanda. This experience was imagined in 2017 based on PATH's previous creation of a virtual tour for a newborn project in Vietnam, which focused on the key features of a human milk bank, an opportunity for anyone to explore this site from anywhere in the world. With the virtual platform, the viewer can actually tour the unit by taking a walkthrough of the space as if they were there in person. Utilizing a similar approach, the Neolins Project will tour a newborn unit, embedding key highlights throughout to visualize best practices across these 4 countries. Beyond visualizing the neonate unit layout as if the viewer was touring in person, multimedia elements embedded will share features such as video interviews of champions from each country sharing the story of the journey to establishing inpatient newborn care and their vision for what is possible to improve quality and access. Photos and layout plans of neonatal units showcasing historical perspectives of establishing care in various settings. Key equipment essential for the care of small and sick newborns, as well as innovations and best practice service models adapted to the local context. The purpose of creating a virtual experience is twofold: to provide users from anywhere in the world an immersive experience into the realities of facility-based newborn care, and to inspire adoption of future best practices by learning from other countries' stories of implementation. We look forward to sharing this virtual experience with you later in 2021.
Well, thank you so much, everyone. This has been a terrific session thus far. Just to highlight again, a huge appreciation to our presenters and to you who are listening in this. Now, there's a Q&A session, which we're going to do now. Unfortunately, we've only got about 3 minutes for this, but then there's a networking session. So all the questions that are in the chat box, we'll hope to address at that point. And if we can't during that session, then we'll follow up again later on. But perhaps I'll take the first question that came up, which was around nurturing care and family involvement, and ask Dr. Queen Dube, are you able to talk a little bit about any success stories, perhaps highlighting some of the KMC work that you touched on?
Thank you, Sarah. So every time we talk about nurturing care for the newborn, for me, that equals kangaroo mother care. And when you look at the WHO standards, we are talking about doing it in stable babies. But we've actually been able to demonstrate do it from the time the baby pops out. Whether they are stable or unstable, you get the maximum gains. There is a paper that should be coming out perhaps in May, multi-country study looking at immediate kangaroo mother care. So what better data could we look out for? So for Malawi, every other facility, over 500 facilities, there is a space for kangaroo mother care. We also have the community kangaroo mother care aspect, that allows women to practice kangaroo mother care at home, but also within the primary health care facilities. So now, with the new evidence, we can safely do it in babies that are unstable, babies on CPAP, babies on IV fluids, on oxygen, and you reduce mortality. Thank you.
That's fantastic. Thank you very much. And perhaps maybe Dr. Assumpta, if we have just a couple more minutes, Are you able to respond to Susan Nehemiah's question about highlighting your leadership in an accreditation and mentorship? And then afterwards, if there's still time, we'll ask our panelists to talk about that as well. But Dr. Assumpta, can you maybe say a couple of words about that?
Okay, thank you. So for Rwanda, what is very good, we have a coordination at central level, but also at district level. At central level, it's the Neonatal Technical Working Group, which is chaired by the Minister of Health, with a co-chair, which is part of partner. Now it's partner in health. At district level, we have also district coordination meeting where we have district leaders who are part of the meeting, where we present data about maternal, newborn, and child family planning, and all the gaps observed on data are discussed, and we look what are the problems, what are the gaps, and it's a place where we advocate to solve all those problems. About mentorship, it's a national program. We work with professional association, Rwanda Pediatric Association, Rwanda Association of Midwife, and now we want also to introduce the neonatal nurse within the mentorship program that was missing. We were missing the neonatal nurse in the mentorship, but now we are planning to do it. And there we'll work too much on nurturing care. We have already Kangaroo mother care, and mother also part of the care. They support feeding, for example. They are trained to feed the baby with a nasogastric tube. So the mentorship program help us a lot, because a pediatrician or midwife from teaching hospital are supporting district level staff. And also we have a district-based mentorship where we have staff from the district hospital who are support the health center. And there it's essentially the essential newborn care, because the inpatient are only at district level. But for essential newborn care, we have staff for district who spend like 2 days at health center to support healthcare provider from health center to take care of newborns. And we have also community mentorship, where we support community health workers through what we call community environmental health officer, who are in charge of supervision of community health workers. And currently we have even introduced e-learning program where we want to teach community health workers to learn from this e-learning program. Yeah.
Thank you very much. Thank you.
Community-based maternal and newborn program also. Yeah.
Yeah. Well, thank you. We're getting a lot of signals from the organizers that we need to sort of move on to the next session. So just to reiterate again, there are a lot of really rich questions that hopefully we can pick up during the networking session. So to all our presenters, panelists, to all of you listening, I think we've heard some really inspiring words from Queen. She's talked about mobilizing resources and rallying around a strong team. We've heard from Dr. Shushma, who's emphasized that we need 4 pillars: the infrastructure, equipment, manpower, and then actually capacitating the manpower for this. We've heard from Dr. Mwali, and you've just heard from her again, and the incredible power of having advocates and champions. And then you've heard from Prof. Bogale, who's talked about the miracle working nurses and just the incredible work, which I think all of us who've been involved in any facility or community-based work and dealing with, having the privilege of dealing with newborns and mothers, understand just the powerful, powerful role of nurses. So with that, we look forward to meeting you in the networking session. Thank you.
Thank you. Thank you.
Thank you.